Hey guys, this is Dr. Steve, and today on the show, we have the #1 ranked health tech influencer on Twitter, John Nosta. This guy's a powerhouse that you're really going to enjoy. He's coming to your ears right now on Red Hot Healthcare. Let's go.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com.
John Nosta is generally regarded as one of the top global strategic and creative thinkers in digital health. He's also one of the most popular speakers around the globe, presenting his vibrant and insightful perspective on the future of health innovation. John is the #1 ranked health tech influencer on Twitter. He founded and leads NOSTALAB, a digital health think tank with such large notable clients as Google, Medtronic, Boston Scientific, GlaxoSmithKline, and many others. You can find him on NOSTALAB.com or on his popular Twitter handle at John Nosta. John, I want to thank you so much for coming on to the show. Welcome to Red Hot Healthcare.
Thank you very much, Steve. It's a pleasure to be here.
We're going to get into a number of powerful subjects today, and I know you and I share a lot of similar opinions on these topics we're going to jump into. I've read you in on the intro. But more specifically, I'd like you to tell our audience where you add value, maybe some of the biggest successes that you've had thus far in your career, and also what really gets you fired up about healthcare today.
Well, I guess, if you really want to cut to the chase, what I often say is that I'm bilingual in the sense that I speak both medicine and marketing. My early background was as a research associate at Harvard Medical School at Brigham, where I looked at cardiovascular pathophysiology. So I have some good fundamental scientific underpinnings. I know what things like 1,6-fructose diphosphate really mean, but much to the dismay of my parents, I decided that medicine was not right for me. And I wanted to really look at more creative venues and look at writing and creative development, and spent the bulk of my career in advertising and marketing in the capacity of chief creative officer, chief strategic officer, and unit president at a very large agency. So for me, what I've been able to do is really kind of craft a dialogue messaging strategy that makes sense to two sides of that dynamic, the marketing and the medicine. And, in today's world, Steve, I think that you probably have to add a little bit of even technology and that aspect of really understanding some of the babble that goes on in healthcare communication today.
Yeah, we talked about this off air a little bit, and I talked about what gets you fired up about healthcare, and you said, you asked me that question, Steve, and it's like lightning bolts going off in my head. And, I really liked when we had that chat. Maybe you could just share a little bit more about that.
There's a couple ways of describing it. One way is talking about it as an inflection point, as a real fundamental change in humanity from a fundamental perspective. The other way is looking at it like a Gutenberg moment. The Gutenberg moment did something really interesting. It made information accessible.
Yeah.
And in a lot of ways, we're seeing that right now. Our ability to go to Dr. Google or to access tremendous amounts of information is extraordinarily empowering. It's empowering to the clinician. It's empowering to the caregiver. It's empowering to the patient. But, the Gutenberg moment, for me, doesn't really capture it, because today it's really bigger than that. We're seeing social changes, technological changes, and this grand sense of wonder about what's coming down the pike. So for me, it's a confluence of interesting events happening at the same time. I mean, for me, it's basically being lucky to be alive now, because we're really entering this key point in human history where this is going to be an era of health and wellness. And I think there are lots of opportunities that are coming to grasp at that.
We talk about digital health today. There's a lot of important technologies that you follow. I know that you sit on the board at Google, among other positions that you hold. Why don't you get into some of the biggest technologies that you see happening today in digital health, and specifically maybe how you see those impacting healthcare moving forward?
Steve, I think this is a very important question because people often define digital health as an activity tracker, as the proverbial 10,000 steps.
Right.
And I think that not only is it wrong, I think it's giving a disservice to this movement. In fact, some people talk about digital health in the context of health tech. They even move away from digital health. So I think there's a bit of an argument about the lexicon of this area. But when I think of digital health, I do think of wearables. I do think about 10,000 steps. But I'm going to take that and put that to the back of the list because I think that we can redefine wearables where they go from what I call an athletic option to a clinical imperative. And right now, the wearable, the traditional wearable, the Fitbit, Fuel, the usual devices, are basically dust collectors that fail to get charged and sit on your bedroom nightstand. They're really not something that's embraced by people who need to embrace it. Sure, the athletic man or woman who goes to the gym all the time, they wear their activity tracker as a badge of honor. And interestingly, I don't think it's a determinant of health, but a device to woo a mate. And I mean that in all seriousness, because it's like, look at me, I did 18,000 steps today.
Yes.
It's bragging rights. It's not my C-reactive protein is down or my HbA1c is down. It's more of bragging rights along the context of fitness. And that's a problem because those are the people who don't need it. So I'm going to come to wearables in a minute, but I want to go to what I think are the really exciting things. And there's a few key points to be made here. The first is that artificial intelligence, personalized medicine, genomics are extraordinarily important and really changing the game. The application of this type of technology to medicine is extraordinary. And we're seeing the emergence of nanotechnology as an example, which is changing the way we track and understand disease. Nanotechnology, in part being studied by Google, has the ability to track abnormalities in our blood or in our bodies and find what many people refer to as stage 0 disease.
Now, what does that mean? When you talk about stage 0 disease?
Okay, well, let's say breast cancer.
Mm-hmm.
Oftentimes, breast cancer is found by either palpation or visual inspection. In other words, a woman finds a lump in her breast, or she gets a mammogram and that picture is looked at with the human eye. That's a state of the disease process, which is pretty far along.
Yes.
And that's a problem because the disease has already infiltrated the organ. It very well may be metastasized at that point in time. But let's just play a thought idea like Albert Einstein used to do. What would happen if we could find the first cancer cell in your body?
Yeah.
If we could find the first cancer cell and we can kill it, we don't have stage 2B or 3 or 4 breast cancer. We have stage 0 disease. And that in of itself is extraordinarily important because the earlier we find the disease, the better off the prognosis is. And that's a simple clinical fact. But let's push on that a little more philosophically. What we end up doing, and I think this is the big idea here, is that if we could find that first cancer cell or find functionally stage 0 disease, we actually share a border with prevention.
Yes.
Now, everybody goes to the doctor. Everybody who reads a book on health or wellness, what do they say? Exercise, eat green leafy vegetables, blah, blah, blah.
Gets people real excited.
It's exactly the stuff that we don't do. Here's that 65-year-old man with metabolic syndrome who we tell him or her to exercise, to lose weight, to stop eating those potato chips when you're watching the Giants game. Well, I mean, it's just not going to happen, right? It's not going to happen. Perhaps, this is my postulate, that the way to prevention is through earlier and earlier and earlier detection.
Yes.
I think that to me is really interesting. Now, does it take the burden off the shoulders of the human? Well, maybe. Does it give us the opportunity to eat those chips while we watch the football game on the couch? Well, maybe. In the same way that many people would eat more meat when they were on a statin because they felt they had this added protection against dietary impacts of cholesterol. So I want to come back to the wearable because, I have a love-hate relationship with all these wearables. And I want to give you an example of another wearable. Let's take those 10,000 steps, right? The proverbial 10,000 steps that people look at as a goal. But let's not measure the steps. Let's put the tracker on your ankle instead of your wrist, and let's track gait. In other words, let's track the way you walk. And in this instance, maybe it's someone who has a movement disorder or Parkinson's disease. So here's where a wearable becomes an important tool for tracking drug administration, the on-off dynamic that we frequently see in treating patients with Parkinson's disease. It's a tough therapeutic window to establish. So here's an opportunity where a wearable becomes much more functionally sophisticated with just placement. And this is not high tech. This is not yes. Nanoparticles. But let's even go further. Let's go look at nanoparticles. Here we have that 65-year-old man who's sitting on the couch. But at this time, he's home from the hospital where he had an MI, he had a heart attack. Or let's go back to that woman who detected breast cancer, who has stage 3 breast cancer. And we tell these two patients that we're going to use nanoparticles to track your disease and see if it comes back. So for the woman, we're going to look for nanoparticles that can detect the early signs of breast cancer recurrence. For the man, we're going to look for the earliest signs of an acute myocardial infarction.
Yes.
Now, this work is being done by Eric Topol at Scripps. They're looking at biomarkers of endothelial disruption. In other words, when we have a heart attack, the plaque in that coronary artery starts to fracture and break, and compounds like thromboxanes are released. And if we could measure those, if we could track them, we can say to this guy, hey, you're having a heart attack. Or to that woman, hey, you're having a recurrence. So the question I ask you is, what happens to the wearable that's placed upon their wrist? It's always charged. It's always there because we've moved it from almost a silly athletic option to a clinical imperative.
John, that last answer that you gave opens up a whole new conversation here, and one that I really didn't have planned until right now. There is a misnomer about sickness and wellness in healthcare, and one that when I was a practicing doctor, in my office was often miscommunicated, and that is that if you feel good, you're healthy. And if you don't feel good, there's something wrong. And so many times in my practice, I'd have patients come in who were 35, 36 years old, and they would say, yeah, doc, you know what? I've just started having some pain in my lower neck area. Just started about a week ago. I'm just noticing when I'm at the desk, it's just giving me some pain. We would go ahead and take an x-ray and see there were 2 degenerated discs. This person had the neck of a 70-year-old. Bone spurs, thinning discs, and they had no idea. They simply felt fine for all these years. Turns out when they were 18 years old, they wound up having a whiplash car accident that after a couple weeks they felt better, but it did damage to their neck, and they just didn't feel the pain. But they had a disease process going on in the form of osteoarthritis. So when you talk about that palpable pea-sized lump in the breast, and by the time you feel it, it's been there for years. And, doctors have known this for years. That jazzes me up for a couple reasons. One, I think we could use it as a much bigger selling point to the patient in terms of their responsibility. And I'm a big believer that when we start working on reforming healthcare, it's not a matter of all the responsibility has to go onto the doctors, the health systems, and to the companies coming out with technology. The patients have a responsibility too. Once you know you have cancer, the sooner you know, the sooner you need to be responsible. And maybe even from a marketing end here, I don't want to go too far off topic, but maybe even putting loss aversion onto patients that say, look, now that you know you have cancer, now that you know you have arthritis or whatever disease process it might be, if you choose to participate in lifestyles that are going to be beneficial towards managing your disease care, we're going to give you benefit. Not just you'll feel better and you'll be healthier, but you might get some financial benefit in the form of maybe lower premiums, maybe lower costs. And if you don't, we have a reason to raise your costs because your sickness and your disease and the way that our health system works with this risk pooling with coverage, it affects everybody else financially. I wanted to get your thoughts on that. It's quite a lot to go over, but I wanted to get your thoughts on this concept of not just being able to let people know they have disease quicker and much more earlier, but then maybe the effects that could have on assigning responsibility to people sooner.
Let's start off with a very fundamental concept, because I think you're beginning to go where I like to be. We're becoming philosophers and really looking at these broad-based conceptual aspects. So number one, we have seen and will begin and continue to see a fundamental shift between two poles of healthcare. And Steve, I'm sure as a clinician, you'll recognize this immediately. We are changing from control to collaboration.
Yes.
In the old days, right? In the old days, and those old days are not that far, you would go to the doctor and he, and I'm saying he very specifically here, would give you a pill, or he would control the dialogue and tell you what to do. Now we're seeing that shift not only in the context of clinical medicine, but we're seeing it in the context of pharmaceutical selling, where pharmaceutical companies can no longer bully their way in with a particular product or brand with a unique strategy that drives prescribing habits. It's much more of a dialogue. In fact, some sales reps are not even allowed in a clinical environment. So the role of collaboration in care is beginning to take off. And that's partly because we now have the tools to track basic physiologic data so that we are really the CEO of our body, that we're the caretaker of our body. Now, with respect to zero disease, I want to raise another issue which I find very, very interesting. We are all born with preconditions. You know, we referenced the woman with the pea-sized nodule in her breast, or the individual at a car accident who had vertebral changes, some disc changes.
Right.
But many of us have a blueprint for disease already baked in. That's our DNA. Think about women who are predisposed to breast cancer, BRCA genes and things like that. So stage 0 becomes a little bit more complicated when you begin to look at opportunities at birth to do potentially genomic sequencing to find out what you might have 20 or 30 years from now. So I think you really are touching on a very powerful construct where people become keepers of their health and leverage technology to get ahead of a disease that may or may not be inevitable.
This is Dr. Steve Ambrose. As a healthcare influencer, I'm in contact with some of the brightest minds and most powerful leaders in the industry. But my best effort comes from outside the booth. Knowing how to engage patients is an art, science, and philosophy that I know very well. I'm a hired gun that brings expertise to healthcare organizations of all types. You've heard my words. Now read my thoughts on my free white paper called The 7 Mistakes Made in Patient Engagement. Just go to redhothealthcare.com/learn. That's redhothealthcare.com/learn. While you're on the site, dive into my consulting and speaking services and schedule an initial call. You won't regret the uniqueness, benefits, and results I can deliver for you. And now, back to the show.
I want to move on to this point here. Some people see digital health as slowing down. Investment continues to pour in, though, at record pace. Is digital health an area in particular where there's just way too much overcrowding at this point with new upstarts and new technology coming in, and there's a need for massive digestion, kind of flushing out a lot of entrepreneurs and also technologies? Or do you still see this market as wide open and able to sort of still take in a lot more companies in the space?
Can I get away with saying the answer is yes and no?
Only if you explain it.
The answer is yes, to a certain degree, that medicine is very sophisticated, and that we see entrepreneurs will advance certain ideas with a certain amount of clinical naivete, and sometimes not understanding the full perspective on a clinical condition. They can come up with ideas that might not work. So on one side of the coin, I think we do have a little bit of that in digital health. We also have some ideas that have fallen flat on their face because the concept didn't work, or even the premise or MO of the company was a bit corrupt. I don't think that's a problem. I think you see that in almost any industry anywhere in the world. But that being said, I also think that there are entrepreneurs who are following a more traditional clinical path that is guided by data. So, the example that we talked about was this use of a pulse oximeter. Now, any of you who are clinicians and were in practice years ago would remember that if someone in the emergency room in the hospital needed to have their blood gases done, the intern or the respiratory therapist would go in and stick a needle in their radial artery and then put that syringe full of arterial blood on a bag of ice and run to the lab. It was a real pain in the neck. And today, the invention of pulse oximetry, that little thing you put on the end of your finger that gives you real-time oxygen levels, is amazing. It's an extraordinarily powerful tool. And in fact, it's gotten so good that it's gotten cheap. What I find is oftentimes you'll see a lot of gadgets or trackers that have pulse oximetry built in. And they build it in because it's cheap and easy, not because it fits an unmet clinical need. So the example that comes to mind quickly, Dave Albert's company, AliveCor. Very simple device that uses your smartphone to take your EKG, a single lead EKG that allows someone to see what's going on with their heart rhythm. What's really become important is now they can track or find a condition called atrial fibrillation.
Yes.
And that's a beating abnormality of the heart that's associated with stroke. And this type of stroke is really catastrophic. So here's an example where a unique innovative device was supported by data. They have about 80 clinical trials. It was supported by a true clinical need, an unmet need. And thirdly, which is just as important, it's easy to use. It's a very simple device that proverbial 65-year-old man with metabolic syndrome is sitting on the couch can use it. So I like to see digital health guided by science and process and data and solid clinical understanding. But here's the thing that really kind of bugs me. I'm completely unwilling to disenfranchise the whimsical innovator from this process, because we never know, after a few stumbles, they might take a step and actually fly.
Yeah.
So I think that new thinking in technology, in finance, in gaming, and in health is extraordinarily important. So I don't see digital health as languishing. I think that many aspects of health tech, like personalized therapy, like immunotherapy, oncology, like AI, like genomics, are extraordinarily important and will take a tremendous foothold and really redefine clinical practice. And along the way, we'll stumble, but that's the nature of the industry today, because we see, as we talked earlier, about the power of the consumer.
Yes.
Who are the people who are making these leaps of innovation? When Apple comes out and talks about their new watch for tracking heart rate, it's people outside of the clinical arena who are making these changes. So for me, I think it's an exciting time, and digital health and health tech is alive and well and only growing stronger every day.
Yeah, you talk about whimsical thought, and I'm going to jump ahead on a question I was saving for you, but it's just a perfect lead in here. I know that you work with a number of drug companies, John, with NOSTALAB. And here's something I wanted to get your thought on. I really believe that there should be a company that creates a secure platform, and essentially there'll be individual drug consumers, drug customers on one side, and drug companies on the other. And coming to the site will be all the patients who essentially can't afford medication. They either don't fill their medication on the initial prescription, which happens very, very often, happening more often than ever now with affordability issues. They don't refill the prescription, or they're looking for some sort of alternative, and maybe it's not being suggested by their doctor, or they don't ask their doctor, but they want to do their own searching. And drug companies on the flip side that desperately want to grow their market share, and they recognize that people aren't following through on their medications. They may be looking to hop into a less expensive alternative, or maybe they want to keep the same drug, but financially they just can't do it. Having a platform like that to essentially help drive down pricing. Maybe it's a person that says, listen, here's my tax returns for the last 2 years, however that gets securely submitted to the drug companies or to this platform. At the end of the day, I want to be your customer. You're pricing it out of my affordability. And at the end of the day, I got a $200 copay for this drug. Can I still be your customer? Can we work something out? And the drug companies, if they could do it in volume, saying, geez, we could really get some brand loyalty here, even if it's for short duration. What do you think about, adding more free market forces like this, particularly onto the drug side?
As we talked, it is a fundamentally complicated question that when you start restricting people access to drugs on the basis of income and starting to stagger the price, it's tricky. But, let's take a step back. Right now, pharma is largely insulated from the consumer. The price of a drug is set, but the real dollars occur in that convoluted path from pharma to patient. And that goes through the pharmacy, it goes through PBMs, pharmacy benefit management. And the interesting thing is that's a complex negotiated rate. That's one of the reasons why healthcare is so complicated, because every time you pay for something, the price is different.
Yes.
And economic forces can certainly try to change that. But to me, one word that can potentially change the game here is Amazon. We know that Amazon is actively looking into the health and pharmacy space, because what the opportunity here is to connect more directly a pharmaceutical product with a patient. Amazon has fundamentally changed commerce. Look what they've done. They started selling books, and they've completely redefined, commerce in the context of retail stores and malls. So I think you may see this sort of disruption from commerce models. And isn't it interesting that we're talking about commerce here, about dollars and payment versus therapeutics and versus drugs? So I think that we're going to see a lot of activity here. And I think it's going to be disruptive to the marketplace and probably change some fundamental things.
10 years ago, this wouldn't have ever been a thought. Why? Because the payers were paying for it. Actually, the truth of the matter is the payers were paying for it, and they were just passing the cost down to the consumer, and maybe to the average consumer or employee getting their benefits through work. They didn't realize that, guess what? It's been 10 years since I've had a wage increase, and guess why? Because healthcare costs are going up.
And they've been taking their cut.
Right.
The cost of a pharma product to pharma, the wholesale cost, and then the retail cost, and the markups, and the pricing strategies, and the contracting, and the rebates, and all sorts of that, I think is very confusing to a lot of people. That frustration is the basis for some initiatives.
When we get into EHR portals and the interactivity between the patients and the doctors and the health systems, those EHR portals came out, and the adherence to those, the interest to those, the stickiness was a lot lower than expected. Really, I think it's true also we're seeing now for individuals with mobile health, with patient-generated health data. A few episodes ago, I had Drew Schiller on here from Validic. We talked about this quite a bit as well. Workplace wellness programs. It just seems as though that patients and individual healthcare consumers, while they do get healthcare and healthcare services, it seems that they're just not really as interested in overall wellness and in managing their health and in participating in sharing that data as maybe healthcare providers thought they would be, certainly as much as Medicare thought they would be. So I'd like to get your thought on, just as a marketing end here, why do you think that people are just not putting the management of their health and wellness as a very valuable facet of how they make decisions and what they want to put their time into?
I think the simple answer is because it's hard. It's hard to do. Look at the lifestyles that dominate communities today. People work long hours. They have children. Sometimes they're working 2 jobs. It's hard to kind of get in these programs where nudge psychology, where an app sends you an alert and says, "Don't forget to walk this evening, John."
Right.
I think that kind of stuff is, it's lackluster to me. I go back to some of the earlier discussions, and I think that the promise is in aspects of technology that could help us find disease earlier, that could treat disease in a way that is fundamentally different. And here's what I think is a big point, an important point. Is humanity overrated? Let's think about it. We're going to replace our hip. We're going to replace our knee. We're going to replace our heart valve. We're going to put a sensor in our brain and stimulate our brain. And by the way, that's not future. That's now. That's old news. That's deep brain stimulation in Parkinson's disease. So, I think that we may look at these sort of tech interfaces as part of the replacement strategy for our bodies. When we have a low pressure in our car, let's say low pressure in our tire, we get a check engine light. And that check engine light says, low tire pressure. It gets on our radar before it's readily apparent as a driver. And I think the same thing will be with disease and health. We'll have check engine lights for our body that will allow us to proactively look for problems and deal with them. And I think that's a little bit like the stage zero, but I think we kind of expand that into the notion of how can we fix and replace. And the interesting part about that is when we talk about fix and replace, we're often talking about the notion of regenerative medicine, not only replacement medicine. So when I talk about replacing the tire on your car, we could also replace the meniscus in a knee or replace some other vital aspect of our physiology by using the body's repair kit. And this is an emerging science now that I think is going to be very, very important. And that's stem cell science.
Yeah.
We talk about immuno-oncology and using T cells and making them into CAR T cells to fight cancer, but we have in our body repair kits that will actually fix the flat tire for us. The problem is that repair kit diminishes over time. I think we will see our bodies becoming repaired in a way that is both functional. Let's go to the store and get a new organ, or let's go get new stem cells that help facilitate regenerative medicine, which I think is going to be a very, very big point in the way we manage health and wellness.
I would add one other thing too, and it leads me into my next question, and that is that even if you have that warning light, even if we get into that zero-level disease and the earliest of detections, I mean, ultimately, I can remember going back to a Tony Robbins book I read years ago that said that people make decisions for one of two reasons. Either they want to avoid a lot of pain or discomfort, or they want to gain a lot of pleasure. They think the decision they're going to make is going to bring them some real pleasure or benefit. So, with that said, even if you have the information, the people have the information, it's getting them to take action on it. Since, you and I are both heavy into marketing and communications, where do you see marketing and communication efforts in healthcare today hitting the right marks? And then where do you really see them completely missing the big opportunities?
Boy, that's a conversation in of itself. I believe that fundamentally the shift is not only related to healthcare, but I believe it goes back to the earlier point where we're moving into a world of collaboration. And the collaborative dynamic will allow us to leverage influence. And influence is a very interesting thing. Today, the influencer, and let's talk medicine here, let's not even talk movies and popular culture. Influencers now are both good and bad and come from a variety of perspectives. A mom who has a child with leukemia, who's very active in social media, can become very powerful. So powerful that she or her community can influence the FDA in approving a drug where the data might be ambiguous.
Yes.
Let's talk about vaccines. I mean, one of the biggest influencers in the anti-vax movement and the autism movement was Jenny McCarthy. Now that was tragic, but her voice was resonant and powerful.
Right.
I think that the influencer status is a big opportunity. Here's the one little spin on influence. There's two kinds of influence if you really kind of break it down to its fundamentals. There's in-network and out-of-network influencers. In-network are the people that you know. Out-of-network are the people that might be in that ivory tower, or might be a celebrity, or might be a rock star, or might be that Harvard professor. And it's really the combination of those two that give a company or a person an extraordinarily powerful buying opportunity. If you're going to buy a car, you go to cars.com or you go to the company website and you look at the specifics on that car. You look at the data. You look at what the gurus are saying. But when it comes time to buy the car, you might want to talk to your neighbor or your best friend who drives it or your mechanic who has serviced it. And what you're seeing is that combination of in-network, out-of-network influencing model that helps build a buying decision that I think is completely analogous to our healthcare model today.
Yes.
One other thing, which I think is very interesting here, and I always get in trouble for saying it, but I'll say it anyway. I believe that the collective intelligence of certain consumer advocacy groups is superior than the physician.
Yes, I agree.
I use parents with children who have serious diseases because they are motivated not only by their head, but by their heart. And if you've ever had a chance to speak with them, they know the clinical trials. They know the drugs in development. They know the compassionate use protocols. They know their child's blood work and physiologic parameters as well as any expert. And they know the nuances of those tests. Look at what they're becoming. They're becoming a de facto expert. How do we take the smartest in the group of thought leaders and leverage that intellect to help drive superior care? And I think that collaborative engagement is extraordinarily powerful. Look, when you go on Amazon, you want to buy something, you look at the likes, right? You look at the reviews, you look how many 5 stars it got, and it's extraordinarily powerful.
One of the interviews I had on the show some time ago was David Goldsmith. He's the chief strategy officer for a company called
WeGo.
Sure. WeGo Health. And I know Jack Barrett.
You have to call him Goldie, though, if you really want to get on his good side.
Now I'm going to go ahead and I'll tweet that out to him. But actually, and I know their CEO. I've spoken with him a number of times, Jack Barrett. I just think they've got a really dynamic platform, and just to your point, I couldn't agree more with you, John. I really feel like that is where things are heading right now, and that you talk about the fact that doctors for so many years, wear their stethoscope as a badge of honor. They wear their white coat as a badge of honor, and patients would look at them in that way. But now that it's becoming more collaborative and non-doctors becoming experts in diseases through personal experience.
And not only, Steve, that non-doctors are becoming sort of powerful collaborators, but we're seeing the non-doctor, and I use that term in quotes, becoming the innovator for new development, new therapies, new ideas, new ways of thinking about how we manage health, from everything from the development of a therapeutic to life extension to the treatment of Alzheimer's disease to payer models. And that's what we're seeing in Silicon Valley. That's the emergence of companies, like Apple or 23andMe, or even, human longevity and some of the work that they're doing.
I want to get your take on something here, John, since we're just talking freely, and I'll probably get a little flack for this, but I think it's worth putting out there. And that is that today there's a lot of talk on AI. It seems to be everywhere, very sexy in the diagnostic data and the care delivery space. I had a guest on recently who's using AI in operational efficiency and the back-end services of hospitals and health systems. One of the questions I asked him, and I want to ask you this as well, is there's a lot of pressure now to make physicians more productive. How many more relative value units can you bill? How many more patients can you see? How much more money can you squeeze out? I know that personally my family doctor gets a lot of pressure placed on him, on regular quarterly meetings. With burnout looming, with pressures going up with doctors, there's a real positioning now for AI to be assisting the doctor as opposed to replacing the doctor. Patients necessarily want to have that human being through the whole doctor visit and in contact. I almost believe that there's a fear here that we have to keep jobs. We have to keep the structure the way it is because humanity doesn't want to think in a direction where they could walk into a doctor's office and be seen by a robot in the next 20 years, and that they might get even better care. And that when you look at cost, the two biggest costs to any company are salaries and benefits, which frankly...
And liability.
Yeah. And you start removing things like leave for pregnancy, fighting over your salaries, personality conflicts, people being sick, vacations, and you start driving up quality, driving up safety, lowering cost, and patient satisfaction can rise presumably in the next, with that. Is that a taboo subject, you feel like, the replacement eventually of doctors? Or do you think that we'll never actually replace the doctor in the future with AI?
If you're doing rounds, if you're rounding with the chief of medicine, the fellow, the resident, the intern, and the medical student, oftentimes that is more an intellectual challenge than it is traditional care. In other words, the resident will ask the medical student questions, or the attending will ask a tough question to the fellow. And they kind of needle each other. That's the human dynamic. That's very much ingrained in medical practice today. But if a medical student took out their smartphone and asked the smartphone what a differential diagnosis is to abdominal pain in a 28-year-old woman, they would be in big trouble. They would be, what are you using a smartphone for? You should know this. So I think there's something intrinsic to the way medicine is practiced. It's a very hierarchical system. And taking out your smartphone and having it come up with a dosing regimen, or having it come up with a diagnosis or a differential diagnosis, kind of puts people off. Now, that being said, I think that we're going to shift completely to the point where when you're ill a few years from now, you might want to have the computer versus the clinician, because the computer is going to be that much better. Empathy and compassion are very interesting old school human terms, but when it comes to care, I want the smartest thing out there helping me get well.
Yeah, and one of the things I think of is the single word efficiency. Well, really capacity and efficiency, because as health systems, as providers are moving forward, one of the things they're recognizing, and a lot of it goes towards physician burnout too. It's not just a cultural understanding, but it's the realities. And that is that with the advent of the EHR, doctors are spending so much more time with a computer than they are with patients. And it's becoming a reality that whether it's the design, whether it's just a natural nuance and a hindrance, it's affecting the psyche of today's doctors. But I do agree that things are going to get a lot more efficient, and I think we're going to see design changes in the technology. We're already seeing it with the EHR, the next generation of EHR technology. John, I want to go ahead and finish up with this question here. It's one that I ask to some of my guests. I think it's really applicable here. Let's just assume right now that you're on the phone with every major decision maker in the healthcare industry. They've got their ear on the phone, they're listening to your words intently, and they're going to take action on your words. What is the one piece of advice that you have to give?
Collaboration is a fragile dynamic, and the best idea is not often put forth by that bold innovator who has all the right answers. Oftentimes, that bold idea is softly spoken, and unless you're looking for it, you're not going to find it. The collaborative innovation process is precarious and can't be just managed in a big and bold accelerator. There's real methodology, and when you do it, fail fast.
John Nosta, the founder and CEO of NOSTALAB. John, I want to thank you so much for being on the show today. Again, for our listeners, John is extremely well followed. He writes for Forbes. He writes a fantastic column for Forbes. I would strongly advise that you follow. You can follow John on Twitter at John Nosta. You can also find a lot of his work and a lot of his success on his website, NOSTALAB.com. So, John, great to have you on. A privilege and a pleasure. I've been looking forward to it for quite a long time, and I will be certainly looking forward to seeing how things evolve and roll out for you in the future.
Thank you, Steve. I'm looking forward to coming back and following up on some of these discussions.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.